See, typically how the growth pattern happens, I think that is very important for the parents to know. A child, up to 2 years of age, bow legs is common. Typically the bowing is natural for the first 2 years, and typically from there it slowly starts moving outwards. It starts becoming more towards knock-knee component. By around 4 years is when the valgus angle is maximum. So this knock-knee component happens. The maximum happens by around 4 years of age.
Okay.
And typically by around 5, they come to the adult orientation. Even the adult bones, they are not exactly completely straight. They are, ideally, again, when we talk about anything, we talk about range. So typically a 7-degree valgus angulation is what we talk about. Valgus is basically just outwards of around 7 degrees. That being said, the normal range would be around 4 to 10 degrees. Anything beyond 10 degrees of valgus would predispose the child to have some change in the mechanical axis. Like I said, although the bones are angulated for that 7-degree angulation or whatever we talk about, the weight bears in a straight line for body. It passes just medial to the center of our knee joint. So any change in the angulation changes the weight bearing axis, and that predisposes these kids to have arthritis and other problems at a later stage. See, I don't think surgery is the first thing we should think about at all. The reason why, the most common reason again here is the calcium as well as the vitamin D deficiency. Again.
Okay.
The first thing we do is basically do a basic endocrine evaluation. We see that, whether this particular problem, whether it, by giving sufficient calcium and vitamin D, we sometimes tend to wait up to even 6 years of age also. What we can do there is basically we do something called as temporary hemi-epiphysiodesis.
Okay.
So what we do is, typically say there is a knock knee. So what we do is basically we put a small plate there, which is called as an 8 plate. Okay. So it tends to arrest the growth of the physis on one end. As in when you arrest the one end of the physis, the other end grows naturally.
Yeah.
And the deformity corrects by itself. It's a beautiful, simple procedure.
Yeah.
It tends to take care of this problem, by and large. Along with that, definitely, if at all there is any endocrinal anomalies, we need to take care of that also. Again, calcium, sometimes there'll be parathormone deficiencies, predispose the child to have this particular problem.
Yeah.
So once the evaluation happens, typically we tend to start them on just the simple calcium and vitamin D, or many a times, the endocrinologists, they tend to take a call on how best to approach this particular child. So from the surgical perspective, this particular surgery is extremely important to be done,
At the
during the
correct
growth
time.
phase.